and answer sessions. Are there any questions in chat box?
No, I'm requesting all the audience to put forward your all the questions no, related to diabetes, field and any other. If you want to know, speakers are ready to give answers.
No questions.
No questions. I'm requesting Dr.
Yeah,
Sepuri Krishna Mohan to please, sir, to highlight no today's evening talks.
See, when there are no questions, the speaker is given to understand that the participants have learnt everything or learnt nothing. I am in a dilemma. This is for the first time in my session. There are no questions. If you have any queries, you can please type, put it in the chat box, so that we'll take it up. We'll address all the queries. I'll just wait for 2 minutes. If there are no questions, we'll end up the session. So I request the participants, you can unmute yourself and ask the question. If you cannot type in the chat box, it's a problem for you. You just can unmute yourself and you can raise your questions. Okay, you can raise your voice, please.
All the participants cannot unmute, sir. Only speakers and.
Acha, they have to give the admin rights.
Admin rights.
No problem. So if there are no questions in the chat box, okay, just wait for a couple of minutes. We'll close down. Which is
Sir, from my end, one question is there, sir.
Yeah.
Sir, there are many insulins available in the market. Short-acting, long-acting, analogs, first generation, second generation. Which insulin is better for initiation time?
See, the money is not the problem. The best insulin on the earth is co-formulation. That is insulin, degludec and aspart still remains the gold standard out of all the insulins available in the market in and around the world. So if money is a barrier, then I would think of some other insulin. Like I can go for the insulin, the biphasic insulin aspart, or the money is still a big problem. The patient cannot afford to even go for this particular biphasic insulin aspart, if not the co-formulation. And the best part of it is we have the genetically engineered rDNA human insulins. The best part is the biphasic premixed human insulins with the BD dosage, and start with the lowest dose, try to escalate along with the existing OADs. That is the best part. And the best part of Novo Nordisk is they have all the insulins in their basket. From the poorest of the poor to the richest of the rich, they have all the insulins according to the need of the patient, lifestyle of the patient, purse of the patients. So I don't say one is good, the second is bad. Only thing is the difference between the reductions in the A1C, reductions in the fasting plasma glucose, reductions in the postprandial glucose, and the incidence of weight gain and the incidence of hypoglycemias. These are all the various factors we need to keep in mind once we decide which insulin suits the patient the most. That is the best answer I can give.
One more question, sir, for here.
Yeah.
For us. Sir, can you please explain about the shoulder effect with premix insulins?
Yeah, shoulder effect is seen with the premix insulin, biphasic premix insulins, not with the analogs, not with the co-formulation. That is the undesirable hypoglycemic effect, where the one component, the prandial component overlaps with the regular component of the biphasic premixed human insulins. That is called the shoulder effect. So we get the undesirable, the hypoglycemic events with the genetically modified rDNA, the biphasic premixed human insulins. That is called the shoulder effect, which is not seen with the either the premix analogs and absolutely not seen with the co-formulation. I've made this question very clear several times. The shoulder effect. We see it clinically very frequently, where the patient doesn't take this the mid morning snack, the early morning snack, and the evening snack and the late night snack. Most of the patients, they do have the habit of taking the three major meal, that is breakfast, lunch and dinner, and there we see this effect, and this is primarily seen with this the biphasic premixed human insulins. So especially with this, when you go for 50-50 rather than 30-70, you find the more incidence of hypoglycemia. The shoulder effect is seen with this particular, and you can minimize it with the counseling the patient to take small frequent meals, and with the three major meal you make it the four additional meal, the early morning and the mid morning and the evening and the late night snacks. You can just prevent it. And if it is a recurring problem, and now the latest recommendations say that the hypoglycemia is not at all welcome. Earlier we used to say a couple of decades ago, in the beginning of my clinical practice days, and 3 decades ago, we used to say that hypoglycemia is welcome and the childhood fevers are welcome. So that when you get a hypo, we can reduce the dose of that particular tablet or insulin, and childhood infections are most welcome, because the babies, they develop the resistance power, the immune system is boosted up with the infections. But that still holds good even today also. You should welcome the childhood infections, okay, provided it is treated by the appropriate doctors concerned, like pediatricians. And from 2012 onwards, with the retrospective the meta-analysis of the all the randomized control trials, see, the inference is that the hypoglycemia can be deleteriously dangerous, especially in the elderly population. Whatever it may be, hypoglycemia may end up in death, and prior to that, convulsions, the metabolic seizures, and after that, coma. And if not treated, the level 3 hypoglycemia may end up with the cardiovascular events, that is either the myocardial infarction or the stroke, and finally the patient may end up with death. And if it is treated properly, still we see some cases, we see the permanent dysarthria and some complications of this thing. So in any way, we should try to avoid the hypoglycemias. So if you want to avoid the hypoglycemias, you should counsel the patient once you start the insulin. And the patient affordability is not a problem. Go for analog insulins, especially the analog premix insulins, and the patient is able to go for this co-formulation. Certainly it's not at all a problem. You don't find the shoulder effect, you don't find the hypoglycemias. And we have seen from the evidence based the studies, and we did not see any nocturnal hypoglycemia or any hypoglycemia after initiation of the co-formulation. the incidence of hypoglycemia was 0 at 3 months, 0 at 6 months, 0 at 12 months.
Thank you, sir. Thank you for your response. Here, one more question related to hypoglycemia itself.
Yeah.
Doctor, how can we manage hypoglycemia associated autonomic failure?
Hypoglycemia associated
with autonomic failure.
See, it is otherwise called the hypoglycemia unawareness actually. That is, the patient gets into hypoglycemia, and if the patient is aware of that, we call it a simple hypoglycemia. Again, hypoglycemia is divided into level 1 and level 2 and level 3 hypoglycemia. The difference between L1 is where the patient gets into hypoglycemia. Per se, the definition right now, the current definition is any blood glucose of less than 70 milligrams per deciliter is defined as hypoglycemia. If the patient is able to identify that he is into hypoglycemia and he is able to take something and he is able to correct hypoglycemia on his own, it is called L1, level 1 hypoglycemia. The patient knows that he is into hypoglycemia and he cannot help himself, and somebody has to help him, that is the friends or relatives or the wife or kith and kin. They have to give him glucose or the sweetened beverages or something else to raise the blood glucose. Then everything settles down. It is called L2 hypoglycemia. And when the patient gets into the coma, that is unconsciousness, and he has to be or she has to be hospitalized, and the doctor has to treat the patient by giving the 25% dextrose to start with, and maintain with 10% dextrose or 5% dextrose, and that is called L3 hypoglycemia. And the patient doesn't know that he is getting into hypoglycemia, no symptoms and no signs of hypoglycemia. That is called hypoglycemia unawareness. That is because of the autonomic neuropathy. The patient doesn't feel the symptoms of hypoglycemia. It's a difficult one to treat actually. So you should counsel the patient regarding this particular hypoglycemia unawareness. You should see to that you start with the minimum drugs. You should try to avoid the sulfonylurea, the insulin, the secretagogues, that is the sulfonylurea groups must be taken off. The glibenclamide, the glipizide, or the gliclazide, or the glimepiride, they must not be used in this particular patients. And you should select the drugs. The latest drugs have come into vogue. To start with metformin, the drugs which act peripherally, not on the pancreas, like along with metformin, you can add the DPP4 inhibitor and an SGLT2 inhibitor. And if the patient is not controlled to the target, you can add a basal insulin, preferably the not NPH, the basal analog insulin, and start low and go slow. That is the funda. So slowly the patient gets accommodated to this particular the regime of the sensitizer, that is metformin, and the combination of DPP4 inhibitor and the SGLT2 inhibitor. You can pass on the benefits of the SGLT2 and the DPP4 inhibitors, as the vildagliptin and sitagliptin have become off-patented, and even the dapagliflozin, the best the SGLT2 inhibitor, has become off-patented in our country. It is available at 6 rupees. So you can make use of that particular SGLT2 inhibitor, which is a potent molecule which reduces the HbA1c along with this particular metformin and this particular DPP4 inhibitor, which will act on the periphery, not on the pancreas, so that will not let the patient down with the hypoglycemia unawareness. And if at all the patient is not doing well even with this, you can change it over to a co-formulation if money is not a problem, so that the patient will not get into hypoglycemia unawareness. See, the basic treatment of hypoglycemia unawareness is to give the small doses of insulin on daily basis. Slowly increasing the dose will slowly control and prevent this the autonomic neuropathy complication, which is called the hypoglycemia unawareness.
Thank you, sir, for your elaborated answer. And here one more question is there regarding variability, glycemic variability. How glycemic variability can be managed?
Acha. Okay. See, there are two components actually. One is the glycemic variability, and the second thing is the time in range, and third thing is blood pressure variability. These are all the new terms that have come up in the past couple of years. Earlier, nobody had any idea about the glycemic variability or the blood pressure variability. It is nothing but the ups and downs, that is the postprandial excursions followed by the dips, that is hypos, the multiple variations in a given day in blood glucose levels is called glycemic variability. And there are the same definition holds good for this blood pressure variability also. So you should see to that you select such a molecule to see that the glycemic variability is very much lessened. For that you need to keep in your mind the concept of time in range actually. See, there are three terms: the time in range, time above the range, time below the range. The time in range is around 70 milligrams to 180 milligrams per deciliter of blood glucose is the euglycemia, that is called the time in range. And most of the times the patient is maintaining euglycemia, that is time in range. And anything above 180, it is called time above the range. Anything below 70 milligrams is called time below the range. So this is the glycemic variability. So you should try to see to that the patient always is fixed at the levels of in the range of the 70 to 180, that is maintaining most of the time, 80% of the time at least in time in range. You should target at least 20%. Okay, the time above the range, time below the range is accepted, but never below 80%. The time in range is not accepted. So once you take care of the molecules which act for 24 hours, that is, see, the sustained release metformin, instead of a plain metformin, you go for an extended release or the sustained release metformin, which is very much available, and you go for DPP4 inhibitors, which are long in action, once a day DPP4 inhibitors, rather than going for BD doses like vildagliptin has to be given twice a day, the 50 milligram. To be honest with you, the evidence based medicine says no trial is done with 100 milligram of vildagliptin SR so far. But for this country, our incredible India has the at least 100 companies have come with this 100 milligram vildagliptin SR. But there are the natural substances, the DPP4 inhibitors like sitagliptin, you take linagliptin. These are all the molecules with the long the T1.5, that is the long plasma half-life of more than 24 hours. So you select sitagliptin. Now it is off patent. It is available at 10 to 12 rupees. The branded ones are available at the 12 rupees. So you can go for the sitagliptin if you want to select a DP4 inhibitor, or you want to go for the best if money is not a problem. You can go for linagliptin, that is the real renal gliptin, and at the same time you can go for this the SGLT2 inhibitor, that is the dapagliflozin 10 milligram. Never give 5 milligram. This is because all the trials are done with 25 milligram of empagliflozin and the 10 milligram of dapagliflozin. So never ever give the subtherapeutic dose, and don't try to make the 25 milligram of empagliflozin half and ask the patient for this thing. Don't do that at all. So you can suggest this as far as OHs are concerned. You can go for the best molecules, and along with that you can go for the if the money is not a problem, you go for the co-formulations which take care of the 24-hour control. That's what I said. The total control is the fasting and the post lunch and any time of the day other than fasting, and the glycemic triad must be met. That is the fasting and the post lunch and the A1C. So they must be meticulously maintained. That is the way how. You see, you should have some discipline, you should have some commitment, you should be very sincere as far as the treatment is concerned for diabetes, treatment concerned for hypertension, the treatment concerned for dyslipidemia, and the treatment is not only with the drugs. I'm not talking about the pharmacological therapy. Before that, we need to start the non-pharmacological therapy for diabetes, hypertension, and dyslipidemia and obesity. That is the diet, exercise, which is called as the lifestyle modification, and the comprehensive term I always tell you, the therapeutic lifestyle changes, that is diet, exercise, and reduction in the weight, cessation of alcohol, and cessation of smoking. These five integral parts, and after that you start the proper drugs for that particular patient that will not let the patient down with hypoglycemia or let the patient into hyperglycemia. So the best I said is the combination of the triple combination nowadays is not the sulfonylurea, the metformin, sulfonylurea. These are not the pioglitazone are not the triple combinations. The best combinations are the metformin, the sustained release, at least 2 grams per day, the maximal dose, and a long acting once a day DPP4 inhibitor like sitagliptin or the linagliptin, and a combination of dapagliflozin which is off patented. The patient is able to afford to go for anything, he can as well go for empagliflozin. I don't find much of difference in between the 25 milligram of empagliflozin and 10 milligram of dapagliflozin. Both are one and same. It's head to head competition. It was earlier head to neck competition in between the empagliflozin and the dapagliflozin. Only when in the initial period, when only there was empareg and the declared TIMI 58 results were rolled out, and later on the empiric outcome and the multiple studies have come with dapagliflozin showing the efficacy, the DAPA HF, the DAPA CKD. So many studies have come into vogue which have clearly shown the benefits on the not only as the lipid, the glucose lowering agent, not only the blood pressure lowering agent, not only the weight reducing agents, and the beneficial effects on the 3-point MACE and the heart failure and the hospitalization for the heart failure, and the benefits on the kidney and benefits on the liver, that make this particular dapagliflozin or the empagliflozin the pleiotropic drug like the metformin and the statin. And all the time I tell you, if money is not a problem, all the time go for at least once a day co-formulation, that is insulin, degludec and aspart. Along with this combination, the patient is not able to get back to the targets. All the time remember the targets. The A1C must be around or less than 7, and the fasting must be around some 80 to 130 milligram per deciliter, and the post glucose or the random, that is nowadays the new term is the casual plasma glucose, anything that is below 180 milligram per deciliter, you maintain that, and you maintain 130 bar 80 millimeters of mercury of this particular the blood pressure, and an LDLC of less than 70. So ABC are met, the glycemic variability also and the blood pressure variability, that also comes down automatically.
Thank you, sir. Thank you for your nice response and elaborate answer given questions. And with this, we are going to end the question answer session. There
Okay.
is no questions posted by the audience now.
Anyway, once again, I thank you all, dear my participants. Right. Thank you so much for patient listening.